Good evening and welcome to my Insta Live session on this Saturday, August 15th. It's Independence Day here in India, and so we're celebrating our Independence Day. And today I'm excited to host a dear friend of mine all the way from England, Dr. Chytra. Now, JC, as I call her, or as a lot of people call her, is a beautiful surgeon. She is a thought leader, and she's also very much into holistic way of life. So if you follow Jonquil, you'll see on her Instagram that her posts are not just about dermatology or cosmetic surgery, etc., but it's also about living life in a holistic, fulfilling way. And she has a fantastic view to life, which uh, beauty. And so that's why I've asked Jonquil to join us today to talk about holistic beauty and the way we can incorporate a healthy lifestyle. Hi, JC. How are you? Beautiful.
I'm good, thanks. How are you?
Very good. Very good. Good to see you.
You too, my darling. I'll just
Oh,
rearrange myself so I'm
I know.
in the
Me
picture.
too.
Let me do it again for you. Let me
Oh
just
my God.
a little bit. Here we go. So, Chai, thank you so much for inviting me on today. It's so
Oh,
good to see you and to connect.
it is. Oh my God, you're looking fabulous. You get even more beautiful each time I see you.
Chai, you're so sweet. I mean, it's obviously Saturday night. I'm going out for dinner straight after this. So, and I know that it's Independence Day today for India,
Yeah.
right? So happy Independence Day.
Oh, thank you for that. Thank you so much. So, how is it? How is COVID? How is England? How's everything for you guys there?
Yeah, you know what? I'm really well, thanks, Shai. I actually feel really well.
Mm-hmm.
Been back in practice for over a month, and
Mm-hmm.
it's really good to see patients again and just, kind of develop that interaction again and that support system. So yeah, we're good. There's areas that are sort of having selective sort of mini lockdowns and whatever, but we're good. How about you?
Yeah, we're okay. I mean, the cases are increasing. We've not yet hit our peak in India. They're expecting it for about October mid. But I think, we've had enough time to learn how to live with COVID now. So everybody's taking precautions and doing what's necessary. Not really just stepping out, but doing what's necessary. So it's good. I think we're learning. It's our new normal, so to speak, for the next few months.
Yeah, let's hope it's only a few months.
Uh, I think so. I don't know why, but my gut feeling tells me by June next year we'll probably be out of this because there's so many vaccine trials going on, and Moderna already is out there. There's a Russian vaccine. India says they'll get theirs in November. The Oxford vaccine is going to come out in October. So
Yeah, I'm hoping April, but June. Okay, so that I love the way that you think that that's a few months. Okay, well, awesome. Let's stay positive about that, and I think that's the thing, isn't it? Even though obviously the industry that we work in, a lot of our patients kind of look to us
hmm.
um, to how we feel about this, don't we? Even though it's so difficult to gauge right now.
True. So, Jonquil, the one of the things I see when I follow you on Instagram, of course, and we've met a couple of times over the last few years, is that you have a very different approach to the way you think on conceptualized beauty. Because I think you think of it as a concept and you're always working at it. It's not that you just see a face and that's it. At least that's what I feel when I see you do your work and your presentations. So, do you want to talk to me about how you approach beauty a bit?
Wow, I mean, this is such a big subject, and I'm really, really pleased that you invited me to talk about it because there's been a number of interviews I've had recently on this subject, and I actually think it's evolving. So on the 1st of October, I'm actually going to be doing a international webinar, 77 countries, on this very, very topic. So the
Wow.
evolving concept of beauty, it's going to be through the AMI, it's going to be through Allergan, so that's the 1st of October. So really what I'm going to be doing is exploring, I've taken some time to really reflect on this, particularly over lockdown.
Mm,
And I've come up with 5 key spheres that I think influence beauty ideals and current beauty ideals. And as you know, I like to kind of look over the history and the anthropology and the psychology in particular of how people behave. So yeah, I've developed this lecture series. It's called the Beauty Mastery. So it's got 5 key spheres, and it's, I look at biology, and I look at technique and maths and art, um, and culture, and how politics and different geography and different cultural elements can really impact these definitions. Um, and when we look back through time, it's always been an important driving feature, irrelevant of gender.
Mm-hmm.
So I think now more than ever, obviously we've got socials, and we've got even more pressure than ever
Mm-hmm.
regarding the aesthetic. I think that there's a lot to consider, and I think I get into this very philosophical state about it, but what really helps to guide me is when I listen to my patients. So, for instance, this week I've had a really, really busy week in clinic. I'm sure you have with your clinics, and it's been very interesting listening to my patients and what's driving them right now, how they're feeling about their own physical aesthetic, but also within. And as you know, like from my clinic, we do a lot to support our patients in terms of an inner beauty principle.
Yeah, I've heard you talk about that, the inner beauty, and I've also seen that you're into yoga and, meditation and the flow techniques, etc. So, how did this all come about? Is it because it was a personal journey, or what got you started into this?
Yeah, I think I've always, as I studied more the yogic philosophies,
Mm-hmm.
I've realized that actually that was such a fundamental part of how I've always lived without even really necessarily knowing about, the true definitions of it or the true history around it.
Mm-hmm.
And then, I've always worked with the psychology of my patients. So, at med school, I was always really, really interested in psychiatry. That's what I majored in from, undergraduate. And we were the first clinic in the UK, well, one of the first clinics, I believe, in the UK to bring in a psychologist,
Mm-hmm.
not just for the patients who have like dysmorphia or other image difficulties, or challenges, but actually for everybody, because I'm so into personal development, and actually my own personal development journey. I know I started when I was 8 years old. I was 8 years old when I started.
Really?
Yeah, yeah. I
Wow.
remember the exact moment, and then from then on, I've always done a lot of reading around the subject. I've always been on courses. In different times in our life, I can be busier and not do as much, but it's been an ongoing thing. And so when I started to do more yoga and really study the philosophy of yoga, it really sat and resonated with me in my heart. I thought, wow, actually this is how I have lived my life, that self-realization process. And then in 2018, I did my yoga teacher training, so in Hatha yoga, and then I did yin yoga teacher training. So it
Mm-hmm.
all started to integrate and come together. And I really felt that my own true self was starting to really come through in the way that I work with my patients even more. So in 2018, I stepped out just a little bit more bravely, I guess. I rebranded my clinic. I expanded my clinic physically. And, that's one aesthetic studio. It's just outside of Manchester. And I started to offer more of these holistic support consultants and specialists into the
Mm-hmm.
into the practice. So we've always had psychologists, but we also have spiritual teachers. We have different kinds of lifestyle coaches. We offer yoga, and we also offer, very importantly, meditation, because I really believe in those classes. And I personally deliver and support this signature meditation that's called One Beauty Project. So it's all around our self-image and that balance of wanting to self-improve but self-accept as well. So yeah, there's a lot of work.
It
Mm-hmm.
is because, I mean, even when you're saying it, it's a lot of evolution, It's not a technique evolution, but it's really like a whole 360-degree evolution in the way you're approaching it these days. So take me through like when you have a patient walk in to your clinic and says, Dr. Shantri, I want something done. How does it start?
Mm. I suppose it depends. It depends on who it is that's walking through
Right.
the door. We all have different types of people that self-select to come
Mm,
and see us personally, don't we? And when I look at my demographic, if we talk in the language of the paper that Stephen Liu and I published in October around archetypes, a lot of my patients will be maybe the correction archetype, where they might have had disfigurement or deformity or scars, but also beautification and transformation, where they are wanting to look that very upgraded version of themselves, or they want to push that boundary but still within the realms of themselves. And so it really is about differentiating which archetype those patients are. Now, again, depending on how somebody is when they walk through the door, I don't want to overwhelm them and deep dive too much in terms of what their sociological and psychological drivers are. But I'd like to sort of get a feel for why they're in and what they're trying to achieve. And then once I've established that relationship, then I try to understand really what it is that's really driving them. I guess I'm somebody who is pretty much against groupthink. I don't enjoy groupthink very much. I think that in our industry, we see a lot of unconscious aesthetics, which is being propagated. I don't think it's anyone's fault necessarily. I think it's multifactorial. I think, patients, of course, ask for things. Service providers, doctors, etc., deliver, what they believe. And then, of course, culturally, we've got the media that influences it. So I do think it's multifactorial. But for me, I really believe in diversity and individuality and celebrating everyone as a unique individual, and how that is expressed as a phenotype through the face.
Right. That's very interesting, though, because you're talking about how to take that patient's journey through and personalize that treatment, as opposed to just look at them as a figure and numbers and digits and a mathematical calculation, right?
Yeah. I mean, obviously, maths is a huge part of what we do, and we have to abide by those mathematic principles. It's crucial. Otherwise, that's how people look strange, and it really is not an aesthetic result. But it's beyond that. My goodness, yeah. For me, I never really look at somebody in terms of numbers or how I'm going to transplant and project my idea onto them. It's a two-way thing, and I mean, you do a lot of teaching as well, Shine, and I think you can either see that or you can't.
Yeah.
You don't think that's true?
I think so too. And I think that's what sets people apart too, right, as practitioners, because patients will understand when you're personalizing a treatment as opposed to when you're just superimposing a treatment. If I think I could call it superimposition in a way. But what is your favorite technique? I mean, what's your favorite procedure? Let's start with that.
Yeah, I would say, obviously, because I do a lot of key opinion leading for dermal fillers, so I like, and I suppose a lot of patients come to me specifically for that work, and then how I utilize that. So it might be that patients are wanting lifting procedures, they're wanting that rejuvenation procedure, or they're wanting beautification. So like if I look at this last week, I think I corrected like 8 or 9 surgical facelift cases. There were different bleph cases that I was correcting, and different fat graft patients. So, a lot of patients come to me that have had surgical procedures and want a non-surgical, non-invasive approach, but with a surgical strategy attached to it. So I really like doing that. I think overall I love complex procedures. I'm not really going to be your cheeks and lip girl, Patients don't really come to me that just want their lips done or a specific anatomical point. It tends to be my patients are well considered, and they sort of step back and say, what do you think? What do you think my overall aesthetic result what can be achieved, and how can I be optimized? And I tend to work best with those sorts of patients, and just sort of take it slow. Like there was one patient yesterday, and I could feel like she had a really high energy to her. She'd had facelift, she'd had upper and lower blephs, and then I just sort of took it down. I kind of took it into this sort of Zen state, and we got into my artistic flow, and I'll do that over a couple of visits. So yeah, of course, I love using dermal fillers in micro amounts just to strategically lift and shape the face.
Mm-hmm.
I love a lot of beautification cases.
Mm-hmm.
I actually think it's joyful, patients that, might be seeing themselves aging or wanting to prevent that, but really just wanting to just optimize themselves to their best condition. I really love doing that. And I think that the term best version of yourself is very overused in aesthetics. But it is a guiding principle. And for me, what's the point if it's just on the outside? I mean, that's not just in terms of what we do, but in terms of diet and exercise and health, that all comes into it. But what are their emotional drivers? Because that's
Mm.
really the reason why people come in to see us, and how aware are people of that? Is a scale, don't you find?
Yeah. It's true. It's very true because I think if we are able to satisfy their emotional need and their physical need, then you've got them for life. And if it's just a physical thing, it kind of wears off. And I find that patients tend to forget how they look like after they've had fillers for a few times. They forget the original face. And now what they have now, that becomes their baseline, and then they're always looking to elevate and elevate, and unless you've made an emotional connect, I feel that it's hard to say no, you look great the way you are. I don't think we need to do more. Do you find that?
Yeah, absolutely, sure. And I think that, we are observers, and to, greater or lesser extents, depending on our own personality
Mm-hmm.
types. Some people are more observers than others. And, that emotional connection that I like to help develop is not just between me and the patient, but within the
Mm-hmm.
patient themselves, so that through education they can start to see their own aging signs, their own changing signs, so that they can look out for those things. But really sort of connect in with, how are they feeling? Let's check in,
Mm-hmm.
and because those things change as time goes on. Our own drivers change, right? We might support our patients through different moments in their life, like after childbirth or after divorce or getting a new job.
Yes.
They're
Yes.
key stages, aren't they? But also there's something like what we've just been through. I don't know what you
Mm-hmm.
found, but like some of my patients that I've looked after for like 15 years,
Yeah.
they started seeing me at like 45, and now they're 60, and then they've never seen themselves kind of just even subtly change that much in those few months. And add in the stress and being indoors more and everything else that's been affected. It's been quite an interesting observation, don't you think? What have you been seeing in India with regards to that?
Yeah, I can see that. I think, because there's like this whole stress. I also have like a lot of younger patients too. And I found that the younger patients were a bit more stressed out. Actually, like the patients that I have in the age group of 28 to 35 were way more stressed out than my 45, 50-year-olds. They were like, oh, it's a matter of fact, we're gonna get through it kind of thing. But the ones who were under 35 found it really stressful. And so I found that my sessions with them, when I see them, um, doubled up in time. I mean, it's not like the patient flow is also half of what it was before COVID for us in India, because people are more scared to come out. But I also noticed that they want to spend more time talking with the doctor, because we've had this equation for like 10 years, 12 years, 14 years in my practice. So they
Mm.
want to talk. So I've like now elaborated my treatment time.
Right, right. Yeah, I think I've um, always had an elaborated treatment time. I guess my patients have always wanted to talk to me, and but yeah, for sure, I am hearing them more now than ever, and yeah, yeah, I think it's very interesting times, the way the impact it's had. Do I think that it's changed how people are perceiving themselves physically? I'm not sure. I think some have grown to accept their aging process a little bit better, and I would agree with you. I would say that that's the boomer generation.
Mm,
I wouldn't even say it's like Gen X. I think I would say it's like boomers that have, that have been a lot more accepting of themselves. I think Gen X down, um, are a little bit tougher, even though I don't know why the Gen Zs are so tough, because like they look flawless and pristine as it is. But yeah. Mm.
Yeah, the Gen Zs, I think, are having the hardest time. But I was talking to another friend, colleague of mine, and her take on it was that they were so used to instant gratification and everything is so fast-paced for them that the habit of waiting something out is just incomprehensible.
Oh, fascinating. So it's a degree of patience that's been cultivated. Yeah. And,
Yeah.
control, I suppose, is a part of that. I suppose with instant gratification, you're always feeling like you've got that control, that instant control and choice. And then when our choices and our freedom are taken away from us, we have to be more patient, and it's hard.
It is. So, when I posted that we're doing this session together yesterday and stuff, a lot of people inboxed me a bunch of questions. So I have a few questions laid out, but it relates to technique of injections. It doesn't have to do with holistic beauty though.
Okay. Okay.
And they wanted to know that, like, when you approach eyes, when you're rejuvenating eyes, because everybody says everybody's technique to periorbital rejuvenation is so different. How do you approach eyes when they have eye bags? That was the
Okay.
question. If they have malar bags and eye bags, how do you approach them with fillers?
Oh, okay, really good question. First of all, it depends on their age, and their gender. What gender of the
Female,
female.
female.
Okay.
Yeah.
Okay. So female, with eye bags, if they've not had surgery before,
Mm-hmm.
then I would probably go with dermal fillers first. I would obviously assess their skin, let's
Mm-hmm.
see their skin condition,
Mm-hmm.
um, and then obviously, as we know, we need to indirectly approach the eye bag. So indirect approach, of course, will be assessing the zygoma, assessing the malar fat pads. Do they have a malar mound? Is there a
Mm-hmm.
risk of festoon? So all of those aspects need to be very, very much considered. Have they been injected before? Is that an area where they've gone straight for tear trough, and actually there is an iatrogenic level of eye bag? Do we need to correct that? Do we need to dissolve some of that old filler in order to get the anatomical tissues back to where they are? So there's a lot of questions around that, but most
Mm-hmm.
definitely the first approach would be an indirect approach using dermal filler. So using a lateral approach onto the
Mm-hmm.
zygoma. Now, depending on ethnicity, and desired aesthetic result, a lot of patients do not want to be widened, right? Now, if you look at a classical Caucasian face that may be very, very oval and narrow, then they may want a little bit of width in that bizygomatic distance. But in terms of perhaps your ethnic demographic, they don't want to be widened. Yeah.
No.
So it's about downgrading the strength of the dermal filler, going for a really soft approach. So where we might use something like Juvederm Voluma in a
Mm-hmm.
Caucasian, it might be even something like Juvederm Volbella, can give a very, very nice little anchor point in that lateral position directly onto the bone. And then really assessing that central position. I think a lot of patients can get away with a really high light reflex point, just
Mm-hmm.
high up onto the zygoma. I think it gives a very beautiful light reflection. It helps to lighten up the eye. It helps to open up the brow somewhat. So I am in favour of a fairly high light
Mm-hmm.
reflection and beautification point. Of course, we need to support the deep malar fat pad. So that would be onto periosteum. And it may be that we need to switch strength for that position. So once that is in place, I then reassess the tonicity of the lower eyelid. So usually there is a sluggishness to that lower eyelid, isn't there, before we start when there's an
Yeah.
eyelid issue. So then I reassess the lower eyelid, and then I may look at the temple. So
Mm-hmm.
often they'll have a deficient temple position, and it might be lower, mid, and upper. And as we know from the data and from the safety data that we're aware of as teachers, really the safest point to start with would be onto periosteum, perhaps the classical kind of swift point, or
Yes.
T, if we're talking about that, then going on to periosteum and just treating that area can help to lift up the eye bag, support the orbital retaining ligament, and give that an increase in tone as well. So that's what I would say is the indirect approach. Sometimes in an advanced case, I may use a subdermal approach and fan upwards into the hairline so that I'm giving even more support
Right.
to the temple. Obviously, it depends on the case, it depends on the safety aspect. I'll use a cannula with that, and then I'll reassess. Do they have a true tear trough? Is it prolapsed fat pads? What do I need to do? So sometimes with that alone, the eye bag, the prolapse might be improved, the tonicity might be improved, the snap test might be improved, and then it might just be some very gentle touch up. Or they may have a true anatomical tear trough that really presents itself in animation upon smiling, in that, particularly through that medial third. And then I'll go in directly. Now, when it comes to tear trough and true infraorbital hollowing, I will pretty much always use a lateral injection point as well, rather than just the medial, because then it creates that fullness, and it can be really unattractive in all expressions. So giving a little bit more lateral support directly onto periosteum, and then just really sort of feathering it, or absolutely micro aliquot down onto periosteum into that medial third.
Oh, that was beautifully explained. Thank you, JC. That was amazing.
Yeah, I feel like I've not really spoken about infraorbital for a few months. So yeah, thank you for the question, whoever asked it.
No, it's a great because it's good because I think sometimes people always wonder like, do I really need to touch the temporals when I'm doing the eye area, the periorbital? And then there's the whole idea that it will support your retaining ligament in that area and then improve upon the stretch, a lateral and a medial kind of stretch. But a lot of people still question because they're like, especially in India, patients always have like a bit of a budget and they're like, oh, I'll give you 2 syringes, doctor. That's all I can afford, even though you're estimating that you may need 3 or 4 for the support. And then you're like, do I put in the temporal? Do I put in the tear trough? So it kind of like, the way you explained it stepwise, I think it clarifies for a lot of people.
Right. Yeah. So to those patients who are like a 2 syringe patient, then if you were seeing me, then what I would probably do is microdose it in multiple areas. And it might not be that the tear trough is treated directly in that first instance, depending on the case, but a little bit into the temple, depending, onto periosteum, just to support that orbital retaining ligament. And often the zygomatic retaining ligament, of course, that can be a really strategic way of using 2 mils at its best, really.
So we have a question here. Oh, it says, I have a flat nose. What can I do to sharpen it?
Oh, okay. I'm assuming that they mean in the dorsum.
Yeah.
So often that radius break point, it can be quite flat. So that position, when we look, if we draw horizontal through the pupils and then through the lower lid, etc., and that point through the bridge of the nose. So yeah, of course, dermal fillers can be used. It helps to centralize the face. It helps to throw off some light through the center aspect, which helps to also slim the face down as an illusion. So I know that in Indian patients that I have, they'll often want to retain that ethnic softness, but sometimes want to just slim themselves down just slightly, a tiny bit of contour. Would that be correct? So yeah, I would go down onto periosteum. I'll use a combination of needle and cannula. I tend to use something like Juvederm Ultra 3 or Facelift. Go down onto the periosteum with the needle at that point, at the radius break point, not to overly project them, because that can look really ugly. You can really see this heaviness that starts to ensue, which actually kind of gives an over fullness and over attraction to the glabella. It can make them look too wide as well if it's
Right there.
Yeah. So it really needs to be specific. And, I'll use a 30 gauge needle and I'll just go straight down, or 27, depending on the product, and just go straight down, 1 injection point right in the midline, dead on to the nearest millimeter, and it can then slim you right down. And then in some patients, they might, it might help them to get a little bit of a linear aspect through that central position. So in those cases, then I'll use a 25 gauge cannula. I'll
Mm-hmm.
use an inferior approach. They
Mm-hmm.
might need some columella support, so at the
Yeah.
base of the nose, to give that, make sure that there isn't any droop, and then give some straightening as well. And even if they look good on profile, just a tiny amount through that linear aspect on the central plane can really give that narrowing.
That is true. And for the doctors watching, I want to just tell you that Dr. Jonquil is extremely experienced injector. So when she's talking about nose injections and it sounds so easy, just make sure that you've got enough training and you're using caution before you decide to try this on your patients.
Thank you, Shai, for that. I appreciate that. Absolutely. Yeah, you know, I think noses is something that I still always, I get into my mode, right? I get into that
Yeah.
state. You know, I don't want noise. I don't want small talk. I don't want chit chat. I want to get into it and I want to be absolutely straight about it. Yeah.
Yeah, in fact, I actually preload Hylace and keep it next to me just in case ever since I started doing all these lots of lectures and especially because I've been doing a lot of the teachings in Asia and then like there's doctors talking to me about all of the complications they have and it's freaky when you listen to it and it's so funny because years before when we used to do it before all the research it was just like a no-brainer, right? You just go in and you just inject and you get out. Like the times I've done glabellar injections, and now I have to, like you said, get into the zone. I'm like, tell the patient so many things, make sure my nurse is there, and then get there. Otherwise, before it was like, okay, you want the glabella? Sure, I'll just put a little bit of stuff in there. So
Yeah. Yeah.
it's.
Yeah, I think that what we do, there should always be mindfulness associated with it at any point.
Mm,
And these two anatomical areas that people have asked questions about, for instance, you know, for sure, lower eyelid and for nose, you've got to be completely mindful and you have to be completely present for that patient. What dose do you load up for Hyalase? Ready?
Oh, so we have a 1500 international unit vial, so we dilute it with 1.5 ml to get 1500 units.
Yeah.
So I just load up that. I load up 1 ml and just keep it ready in a syringe because I'm like, I'd rather discard a Hyalase than go and then dilute and do it if necessary. And I only do that when I'm doing like nose injections or if I'm doing forehead injections. These are the two areas I keep my Hyalase prepared. I remember I was training some new doctors a few months ago before COVID, and they were like, "Why are you loading Hyalase and keeping?" I'm like, "Because I'm training you guys, and if something happens, I want to be able to." Help you out right away on the spot. And I said, if you're new injectors, till you get really comfortable and, confident, I suggest you do the same. And Hyalase is not really expensive in India at all. It's like, I think it's like £3. So,
Wow.
yeah,
Wow,
yeah.
it's not like that in the UK. Wow, my goodness. Which begs the question that doesn't seem quite ethical, does it? That it's definitely not that cheap. But yeah, I think that's a really great approach actually, and particularly because of the level of teaching that we both do. It can be very stressful as a teacher, can't it? Like standing back and just watch them in any anatomical area, but particularly the nose. It's high stress.
Yeah. So sometimes I'll like like if they were now I don't train novice injectors anymore. I train the advanced
Yeah,
injection classes. But when I used to train novices, I would actually hold their hand physically to get them to move, to get them to understand how it feels when you're entering through the subcutaneous, you know? I think yeah, it was just too much hand holding. I
yeah.
think I was doing it. All right. Another question we have was how do you work with the jawline when people are like, like I think this is a great question that I also want to ask you because sometimes people talk about filling into the marinate folds and because people do get hollower in this area and you're relaxing the DAO muscle, but sometimes when you overdo it you're still gonna see that slackiness in the skin here and you tend to see this overhang here because of the ligament. How do you deal with that? Because otherwise it just is like this, not just the pre-gel sulcus, but the whole hang. How
Right.
do you deal with it when you're doing dermal fillers?
Right, nice question. Thank you. So of course, what's contributing to this may be, of course, the mandibular ligament and that insertion at the prejowl sulcus, ahead of that jowl buccal fat position. But of course, there may be some descent. So there may be some slight mid-facial descent even. So we might have to do just that slight anchor point. And as I said, in my Indian patients, don't want to widen them, don't want to make them necessarily, in a lot of my patients, look more round. So might use just Volbello or a soft product to give that anchor point onto the lateral zygoma. Then reassess, there may be some pre-parotid hollowing. And even if there isn't, there is a very sleek way of injecting with a cannula at this point, and then going posterior and laterally. And actually it gives that lift, but it doesn't volumize the patient.
Right.
So again, downgrade the strength of the dermal filler choice and give like a lifting technique. And I go really subdermal. It's very superficial with that. I'll use like a 50 mil 27 gauge cannula if I'm using a very soft product, and just really go into that pre-tragal position. And that will give that really nice lift. So that's what you're wanting to do in that position, into the high up point of the marionette, in that buccal heaviness that you may get. Then reassess the jawline. So even if you might have even mesenteric hypertrophy or that classical sort of slight fullness to that angle of the mandible, from a subcutaneous fat perspective, it might be that, again, you just use the same technique, but go down to periosteum, use a light product, really establish the angle of the mandible, and use like a 0.02 mil injection bolus. It will not widen. If you get it right and just use a very small, soft amount, it won't widen the patient and it won't masculinize the patient if the patient's female. Then that will help to give that lateral traction or that superior traction. And then I reassess. So obviously it's about never injecting the buccal fat, never injecting any of that area directly. One of the techniques you might have seen me do live try is if I'll use like a more central medial approach, I'll use the cannula and I'll just start to feather up and fan up to that marionette fold. Yes, if we go more superficial, that will help to reduce the power of DAO and DLI, all those other muscles that might be overstimulating but actually softening. And that can certainly help that transition point. It helps to disguise it, right? Because that's what we're essentially doing in that position. It's like that disguising, that camouflage, and making that transition point more soft. So rather than just thinking, right, I just need to treat here, it's about how do we lift away from it without volumization. And even for those patients that only want the 2 mil approach, you can do it. You might use 1 mil, so you might use half and half, and then use a quarter in each injection point, and that can just give a slight
Yeah, so it just comes down to the whole concept of where the origin is and where do you want to lift from. But tell me about this downgrading of the product, because sometimes we see people where they've put the product here, but it's suddenly their face just becomes like a square for women instead of the nice oval. What happens is they start jutting out at the jawline because somebody put a lot of filler in there. So is that because of the type of filler? Like, is it because the filler was more cohesive? What do you think? What filler do you like here?
Yeah, so again, it depends on gender. I think obviously jawline has become increasingly more popular over the last 2 years. It's become a real trend. And I think that's a good thing. I think a lot of people want to feel that more strength around the jawline as we get that mandibular resorption. But as everything, like cheeks, lips, everything, it can go too far and it can be in the wrong hands. So again, it's multifactorial. It won't necessarily just be the product. It's more about product choice and the artistic assessment of that patient. So, why women are being masculinized to such an extent, really, I think comes down to the position of the injector. I think that if that patient's wanting to look more beautiful and wanting to associate as feminine, then they should be using a softer product, or you can still use a stronger product, but use a lesser amount. So, you know, a large bolus onto the angle of the mandible in a patient that doesn't have a huge amount of soft tissue cover and hasn't been born with a definitive angle of the mandible, it's going to make them look wider and more masculine.
Yeah.
Now, some patients might look at socials and think, well, that looks great because everybody else looks like that, but that doesn't necessarily make you your most beautiful version of yourself. So, yeah, I mean, obviously I launched Juvederm Volux last year at AMWC live, and I did use a combination of onto the periosteum. I used a bolus technique and I used the cannula. But those patients, they needed a slight more definition at that point, and they had significant submental fullness that needed to be lifted up. But on the AP position, they weren't widened, and on the oblique and laterals, they weren't overly squared. They had a slight more definition that was probably around about 128 degrees. You know, that would probably be right.
That's a nice thing to get. But yeah, that's a good one because I do see that, like, you know, because it's getting so popular, people are just going and injecting, and I think a lot of times they think that more volume means more lift, and they don't realize that it's actually a 3D effect. It's not just a one position or a unipositional effect.
Yeah, and just as we've seen throughout the years, people just looking at themselves from like this. Often with the jawline, people are just looking at themselves from oblique and from profile, but they need to remember looking from the AP, from the frontal view, you know, how much is that widening? So if you do have a patient who's already wide, I like to use maybe a potentially softer product, but still Volux can do a nice job, but use the cannula and use a subcutaneous approach. And again, sort of lift backwards, and it will just give that slight soft kind of lift and transition rather than any projection. You know, I think there's obviously there's a lot of people that debate whether or not fillers can lift, but certainly for those of us that use a lot of it, we know that they can. And in many patients, projection and volume is not a desired result. It's more about lift and softness.
Yes, it is. You're right about that. Do you have any tips or tricks for treating neck?
So for, I guess there's so many different things that we need to consider with the neck. Is it skin quality? Is it crepiness? Is it horizontal necklines? I know that that's obviously often a common problem in the population. Submental fullness, platysmal bands. There's so many things that can go on with the neck. Platysmal bands, I still love the use of toxin, definitely to improve the platysmal bands. Micro Botox into the horizontal lines as well can do a nice job, those necklace lines. Obviously I did a lot of work with Volite, did the clinical trials, and that can improve the central crepiness and also the horizontal necklace lines as well. When it's used in micro aliquot, I always go for a subdermal approach with that. I go a little bit deeper. And I also love Profilo. I like Profilo. I use it with a cannula. I'll go through don't usually go through the midline, but I'll use a lateral approach and sort of fan upwards. Gives a very, very nice result. So not necessarily.
We don't have Profilo.
Oh, don't you have Profilo? Yeah.
Yeah,
I guess it's
but
more popular.
I've been hearing good things about it, and I've actually had a few patients who came in from Europe, and they were like, "Doctor, do you have Profilo?" I'm like, "No, we don't have Profilo in India." But do you ever use like threads, like thread lifts and thread lifting? Do you do that?
No, I don't. I have used it in the past, but I must admit I don't really use it now. I think I just use other modalities so much that I feel can deliver that efficacy that I feel I can rely on. I like something that I can get out and that is reversible. So personally, I haven't been using a lot of threads. The other thing that I'll use is HIFU. So I will use HIFU for the neck area, and of course cool sculpting. I used to do a lot of liposuction. I don't anymore. So I use cool sculpting, and that helps to just debulk that submental and submandibular fullness to give that extra bit of lift. Of course, if there's enough of a fat deposition in those positions.
Nice. So, JC, what would you tell to doctors who are intermediate in their practice? Like they want to go to the next level. They've been injecting for a while. They understand the concepts, but they want to uplift their practice and they want to go a level up. What should they be aiming for?
In terms of their aesthetic techniques.
Yeah, and then also the development, the overall development. Because remember, like I think maybe 15 years ago, we would just like look at patients, look at what we would do and stuff, and then you've evolved in your journey really beautifully. And then I feel like I've evolved in a certain way. So I think if we can tell our intermediate practitioners how they should think and what should the steps or milestones that they should put for themselves so they can evolve in their practice as
Right.
a person and a doctor.
What a beautiful question. Wow, that's a huge, huge topic. I suppose safety has to always be the first point. So sometimes we can become a little bit more cavalier,
Mm,
thinking that the more advanced we become, we can take our eye off the ball. We can take things for granted, and as an individual as well. And I think we can never take anything for granted. I think we must always be focused exactly on that patient that's in front of us in that exact time point, and making sure that we're keeping that patient safe. So even though we might be upgrading our skills and doing more challenging anatomical areas and looking for more challenging outcomes, we've got to keep the patient safe. And with
mm,
that comes always checking for our inabilities, being honest with ourselves about that, and our blind spots. Which areas do we tend to not treat, or we tend to be a bit nervous of, or they're probably the areas where we need our most training. It's like
yeah.
anything in life. Anything that we tend to avoid is probably our greatest area of growth. So have an honest conversation with yourself. Which areas are we constantly avoiding, or we don't even see? You know, quite often you'll see when you're teaching, people don't necessarily see specific areas of the face, different subunits, and they won't look at the patient in different angles. And of course, expression now more than
Mm,
ever in the last few years has become, a huge topic. So really observing which areas you avoid, and then observing patient after patient. That mastery level comes with seeing thousands of patients and looking at how they look in different in positions, in different expressions, and how can you optimize that. So yeah, I think there's a lot of self-honesty,
mm-hmm,
further self-growth,
mm-hmm,
considering different anatomical areas, always keeping safe. Like I said, with my lecture series, there's like those 5 components. So things like biology and culture might not be as much
mm-hmm,
of an importance for that
mm-hmm.
point, but really when you're getting to a master level, I think it does become more important, so that we shouldn't always just be projecting our own beliefs onto a patient. They might have their own definitions, so that needs to be considered and listened to, and we need to support them on their safest journey. But yeah, technique, maths. I think if you're an intermediate injector, really understanding the geometry of the face, really
Mm.
studying the different literature around different canons, different scoring systems, um, and art, of course. Try and have a little look at great arts of time, and the great artists' portrait work, portraiture. It gives you an idea of what in a great work of art you can retain that might not look perfect, but allows somebody to still be their own great work of art.
I think that's very well put. It's true. It's development in so many aspects, right? And it's looking, and also I think like you nailed it, honesty to yourself. It's so easy to get caught up and say, oh, I'm good, I'm really good at all what I do. But to be honest and say, actually, I think I could improve upon this and to seek out improvement in that aspect, I think that would be a mark of greatness. And, at the end of the day, everybody wants to be, like you said, the best version of themselves,
Mm-hmm.
not just to look at, but to even like as an injector or a doctor or a physician, etc. And I think constant learning, and it starts with honesty.
It
You're right.
does. I think it starts with honesty and humility and gratitude.
Mm,
You know, Grateful for the fact that we're in that position, grateful that the patient's in front of us, and then humility, you know, what do I still have left to learn and grow in, and honesty with that. So yeah.
Yeah, and it's true. Like I still feel like every time I teach, I still feel like I'm learning and learning, and I come back and I'm like, "Ooh, that was some new thing. Let me work on that concept," and it always keeps sticking my head. So that's how I really enjoy teaching.
I completely agree with you. And every single time I do as well, it's wow, you know, well, how much have I learned from that experience? And I personally find that those situations put me in an increased ambient flow state, you know, because
Mm-hmm.
you're being challenged and you're seeing different things and having to think more innovatively. Or even if you're regressing to a very basic level, it can change your perspective on things. Again, you have to reevaluate your perspective. So I agree completely. Definitely feel in a flow
Right.
state after teaching.
Excellent. So thank you, JC, for
Thank
joining us
you.
today.
Are you going to keep this?
Thank
Are you going to save this live?
Yes, I will. I will save it on the IGTV, then I'll send you a link for it.
That's
I
great. Yeah,
will.
I think it's been some really lovely questions. So thank you for everybody that's asked those questions. I appreciate it, and thank you, Chai, for the invitation. I've really so
Oh,
nice to connect. It's
thanks.
been so long I haven't seen you, and happy Independence Day, India.
Thank you so much. And I think all the Indian doctors will love it. And of course, we had a few questions which I didn't ask you because people kept commenting on how pretty you are and how gorgeous you are. So I didn't bring that up. But JC, you look amazing. You
Thank
just
you
look
so much.
so beautiful.
I love that
And
jade
so
color on you. It's beautiful.
thank you. So stay healthy, stay
You too.
safe, and then we'll catch up soon and we'll chat soon for
Yeah,
sure.
yeah. Okay. Love
Thank
it.
you.
Thank you, Chai. Night
Thanks.
night.
Thank you. So that was Jonquil Chantry, and she has a beautiful thought process. The reason I thought it was nice for us to listen to JC is because she's so inspiring in the way she's evolved in her work, her flow pattern. And I think that's what it is, that we all must evolve, and change is constant, which is the only constant in our life. And so thank you for joining me this Saturday evening. And I will save this on my IGTV live, and you can go back and have a look at some of our conversations about self-evolution, holistic beauty, and of course, some advanced technique for injectors. Stay safe, stay healthy, and happy Independence Day, India again. Bye. Good night.